We're going to be talking about thyroid nodules. We can get questions on thyroid nodules in the USMLE Sub2CK, the MCCQE1, and even just the patients that you can come across both in the outpatient setting and inpatient setting. When we see a thyroid nodule, we're going to talk about, what we should be thinking, the various labs, tests, physical exams to possibly do, and how we can go about evaluating it. Okay. So thyroid nodules can either be found by the patient themselves, maybe when they're, I don't know, feeling their neck or they have a lump in they feel like they have a lump in their throat and that's what they come in complaining of. Or it could be found by the physician when they're doing a neck exam and they're palpating and they feel like a lump around the thyroid area. It could also not be, found by the patient or the physician, but maybe by imaging for something completely unrelated to thyroid. So for example, if the patient, is being evaluated for carotid stenosis and they have to do a carotid ultrasound, which is, about the same region, and then they find a nodule, thyroid nodules can be found that way. Or maybe they require some form of head and neck CT and the thyroid is found through the imaging, but the patient doesn't have symptoms. In such cases, we call those incidentalomas. Regardless of if the patient presents or presents with a thyroid nodule or the physician finds a thyroid nodule in exam or we just find it on imaging or it's just an incidentaloma, we still need to evaluate for the different types. As long as it's a thyroid nodule, we want to take a look at it. We don't ignore the fact that the patient didn't have any symptoms, therefore we don't evaluate in the case of an incidentaloma, because both the incidentaloma and a symptomatic one can have the same chances of being malignant, and we don't want to miss a cancer in our patient. So on the topic of being malignant, that's the first thing we want to make sure the thyroid nodule isn't, okay? So if you get a question asking you what is the one best way to be able to differentiate a benign versus a malignant thyroid nodule, the answer is FNA. Doing a fine needle aspiration, fine needle biopsy is the best way we can tell a benign versus malignant. Is the best diagnostic exam we can use to tell the difference between a benign or a malignant thyroid nodule. So as with all our patients, we want to take a good history and physical, and there will be some labs and imaging we want to do when we have a patient that has a thyroid nodule. Okay, so what are we looking for in the history? If the patient has a history of a head or neck cancer and received radiation as a treatment form, then we're thinking more a malignant route of this thyroid nodule if that patient has that history. Also, the patient has a family history of thyroid cancer, that rings alarms. The patient has a personal medical history that falls in the category of MEN2A syndrome. So for example, if the patient has a pheochromocytoma or, parathyroid history of parathyroid hyperplasia, then, that picture gives us a more malignant thyroid nodule looking situation, okay? And then on the head and neck exam, if the physician is if you're able to palpate, the nodule, then it's most likely 1 centimeters or greater. And, that's one of the characteristics that will make it qualify for a fine needle aspiration. We want to look at the TSH, thyroid stimulating hormone levels, because that can give us some idea of how the thyroid is functioning. So if the TSH is below normal, subnormal, then the nodule is probably producing because of the negative feedback. If you have elevated T3, T4 levels, it's going to decrease the amount of TSH that is being made. And then if the TSH is elevated, then the thyroid nodule is most likely not producing so much thyroid hormone. So the TSH, the brain's trying to ramp up the TSH levels to be able to make the thyroid, make more thyroid hormone if that's the case. It could also be normal. So depending on what you find, it's important to do the TSH to evaluate such patients. The other thing you want to do is the thyroid ultrasound, because that gives us a lot of good information that we can use to, first of all, locate where exactly the thyroid nodule is. In the event that we are going to do an FNA, we know a fine needle aspiration, and we know exactly where it is. It could also tell us information about the size and if it's already encroaching into different organs or systems within the neck region, like the recurrent laryngeal nerve, for example, if the patient isn't already presenting with symptoms that shows, extravasation or infiltration around the nerves and vessels in that area. So this is an algorithm I just wanted to share because you can find this algorithm in, QBack explanations and step review books on what to do if you suspect a thyroid nodule. Okay. So when we do the ultrasound of the thyroid nodule and it fits sonographic classifications for fine needle aspiration, so it maybe has microcalcifications, is greater than 1 centimeters in size, it's extravasating or encroaching the areas of different nerves and vessels in the neck region, then we go ahead and do a fine needle aspiration. Okay, it can tell us whether the nodule is benign or if it's malignant. So that's easy. Is there cancer? Is there not cancer? If there is cancer, then we want to do surgery, refer them to surgery to take it out. Nice, simple, done. But if it's benign, then we want to just keep observing the patient and maybe repeat a fine needle aspiration in a certain interval or repeat the ultrasound in a certain interval to see how much it's changed, if it's stayed the same. And depending on what we find, we can go about the different path in the algorithm. So now what if the fine needle aspiration doesn't tell us whether it's benign or malignant, like we can't tell from the results? Then we go ahead and do a thyroid scan. Now, the thyroid scan lets us know the function. Yes, we have our TSH already that can give us a sense, but the thyroid scan will actually show us if, that the nodule in that area, the entire thyroid or whatever we find there, if it's actually producing thyroid hormone. If it's hot, that is, it's showing that it's productive, then we just want to continue to observe the patient, maybe do a repeated TSH, repeated thyroid exam, and follow up with the patient. But if it's cold, that is, it's not producing any hormone, then it's most likely malignant and we want to take it out with surgery. So I got a question here for us. I made this question based on my experience with thyroid nodule questions on Q banks that are used for, board exams. So you can pause, read it, and then guess what your answer is and continue to play the video. Okay, so a 67-year-old male with a history of neck sarcoma that is in remission after treatment comes to your clinic reporting a change in voice and lump in his throat. On physical exam, you notice a nodule in the thyroid gland area. He reports feeling well and having no other symptoms. Based on the most recent workup from the patient's oncologist, we're certain that he is in remission. What is the next best step in evaluating this nodule in the thyroid region? Is it A, nothing, because he's probably just worried about the neck sarcoma, which he doesn't have right now? B, should we do some TSH because he might have hyperthyroidism? C, should we do an FNA, fine needle aspiration, because this nodule is most likely malignant and we have to rule that out? D, should we do a thyroid scan? Even though he has no symptoms of hyperthyroidism, we need to check if the nodule is active. I chose C, fine needle aspiration, because of some important things in the question. Okay, patient has a history of neck sarcoma, so by putting that he's in remission, I'm going to assume he received treatment, radiation in this case. And then also now he's reporting change in his voice. So a nerve in the neck region is being affected by this nodule, most likely. And then he can feel a lump in his throat. Okay. So on physical exam, we feel a nodule in the thyroid gland area. So those ring bells for me. And I would like to evaluate to know if this is malignant or is something we shouldn't worry about it. And the FNA, the fine needle aspiration, is the most definitive way we can rule this out, diagnostically speaking. Okay. So we can talk about why A, B, and D are not the best answers. We obviously don't want to do nothing. We have a patient with a history of neck cancer who's coming in with symptoms of something affecting his, the nerves in his neck region. We don't want to just send him home. We at least need to do something. Okay. And then B, TSH, he might have hypothyroidism. So TSH is one of the labs we would like to get to evaluate this thyroid nodule. However, it's not necessarily because he might have hypothyroidism, although we want to evaluate for that. But this question is really pointing towards the malignancy of the thyroid nodule that we need to evaluate with fine needle aspiration. Okay. And the symptoms of hypothyroidism usually present with skin changes, temperature sensitivity, changes in bowel habits, constipation, and that's not really the picture we're seeing here in this question. And D, a thyroid scan. Even though he has no symptoms, we need to check if the nodule is active. So he does have symptoms. He doesn't have symptoms of hyperthyroidism, but he is having symptoms like the voice change and also presenting, sensation like a lump in his neck area. So thyroid scan is something we may do along the lines in taking care of this patient, but I want to really consider the next best step. Okay. So let me know what you think about this video and the questions. If there's anything that I missed or anything you'd like to see, feel free to put down your suggestions in the comments below. And whatever you want to contribute about thyroid nodules and how it relates to, taking the board exams. Okay. Thank you for watching.